Good afternoon, everyone. Good afternoon to our virtual participants for the AppCom Community Summit. We are down to our last session today. For the No Time for Excuses, U equals U in Asia and the Pacific, Part 4, we are going to discuss, or we're going to have a conversation about the U equals U and its key messaging and its integration in the national HIV programming in Asia. The U equals U is a landmark finding that was announced or shared during the 2018 AIDS conference in Amsterdam, the Netherlands. And from then, there was a lot of support into the principle of U equals U, as it reduces stigma and discrimination against people living with HIV, as well as increase the access of antiretroviral therapy to effectively suppress the viral load and prevent the spread of virus. But I will not be alone this time, and I'd like to welcome the moderator for the session for this afternoon, Dr. Nithya Panupak from International HIV Research Institute, or IHRI. Good afternoon, Dr. Nithya.
Good afternoon. Thank you very much, Nat, for your introduction into this session. Can you hear me well?
Yes, we can.
Okay, thank you very much. So, welcome everyone to the last session of U equals U in Asia Pacific conference. My name is Nithya Panupak, and I'm the Executive Director of the Institute of HIV Research and Innovation, or IHRI, based in Bangkok, Thailand. I'm also the IAS Governing Council member from the Asia Pacific, and also the member of the IAS Educational Fund thematic working group. So thank you all of you for joining us until this session. And during this session, the title of this session is U equals U and HIV programming, which I believe is the one of the very important component when we discuss U equals U. We have been hearing the science of U equals U from Dr. Roger, from Bruce. We have been hearing what the communities have been doing, trying to communicate U equals U in certain cities or certain countries. And now we would want to hear how the messages has been integrated into program so that it's have been taken into the real action. So we'll have two panelists in this session. Baby Rivona and Ronvin Paktakan. So now let me introduce our first speaker, Baby Rivona. Baby is the founder of Indonesian Policy Women Network, and has advocated passionately on behalf of women living with HIV and AIDS in Indonesia since 2005. She herself is a woman living with HIV, contracted the disease through birth, and also she is a mother of an HIV negative. So she also worked in increased understanding of the sexual reproductive health and right as a national trainer, and reduce risk in the parent-to-child transmission for women living with and affected by HIV. Baby will be talking about integrating U equals U HIV programming through SDC. Baby, the floor is yours.
Thank you. Thank you, Dr. Thank you. Doctor is already introduced me. My name, just call me Baby. Even you don't like me, also just call me Baby. So when we are talking in Indonesia, especially U equal U, I'm very proud of myself. If I'm talking on my own perspective, for 17 years, I've been living with HIV. I'm undetectable, so I'm untransmitted. But officially, as a program, as a national program, officially, the government not promoting the U equal U for a long time. Yeah, but we still holding the 3-0. Zero discrimination, zero new infection, zero death-related AIDS, and zero discrimination through the 90-90-90 strategy, which is the third 90 strategy as a spread. But as official program, the government not promoting you equal, but still promoting the how people knowing the HIV status. That is the problem. So the U equal U initiated by the community itself in Indonesia. So I'm part of this movement building in Indonesia, and I'm very proud to be part of this campaign also. But how we can advocate to the government to make this official program in national level, we're going to achieve that. But the government providing the free of viral load. We call last month is viral test month, and for everybody. So this is one small step from the government to go to the U equal U actually, but also we're facing a lot of challenges in terms of U equal U campaign or promoting this among community. For example, the procurement of and supply chains management ARV, and also the distribution of the ARV. So how people can undetectable if the stock out happening. And also the new regimen like TLD availability is still limited in Jakarta only at the moment. And also, like myself, the nevirapine still continue using by people living with HIV as long as you don't have any health issue, the doctor says. So continue the nevirapine. So this is happening in Indonesia. Just this year, we start our movement building among the community through the social media to promote the U equal U to reduce or eliminate the discrimination to the people living with HIV through the undetectable and untransmitted for our partner, for our children, etc. So this is what happened at the moment in Indonesia. So I'm not talk too much, and I really want to discuss more from the audience if they want to know more about the Indonesia movement. Thank you.
Very much, baby. Thank you very much for that very frank storytelling from what you have experienced in trying to make U equals U kind of an official statement. We will surely get to learn from you more after we hear from Vin. So now I'm going to introduce our another panelist here, Dr. Ronnie Vin Paktakan, or Vin. Vin is the founder of Yourself. Vin is a nurse, educator, and practitioner prior to starting Love Yourself. Has a PhD, a master's in nursing, and BS nursing degree from UP Manila. Believes that self-worth is an empowerment tool that helps the most affected populations, such as MSM, gain confidence and in turn adopt safer sex practices. Under Vin's leadership, Love Yourself has established 7 clinics, which rank as the top most visited in the country for HIV screening. And also one of the clinics is the first transgender clinic, the Victoria by Love Yourself. And Love Yourself also established 15 community centers over the Philippines in partnership with different local CBOs. We have heard from the last session many inspiring activities of the Safer Now Philippines. So we will hear from Vin about U equals U in healthcare environment. Why is it important to talk about U equals U, and why is it important that people living with HIV themselves should know about U equals U? Vin, the mic is now yours.
Thank you, Dr. Nitaya. And I hope to see you soon. So the first question that was given to me is that why is it important to introduce and discuss U equals U in the healthcare setting? So I have several pointers to share. Number one is that as healthcare providers, we notice that it helps improve the adherence of our clients. So because by knowing that you are undetectable and you cannot transmit the infection anymore, it kind of gives hope to our clients, which in turn creates better adherence on their end. So whenever we do our HIV 102 and discuss the medications, some of them get a little bit, anxious about the side effects and all those things. But once they hear about, after 6 months of continuously taking the medications up to a year, and then the virus levels in your blood goes to an undetectable level, therefore you become untransmittable. It creates better health-seeking behavior for them. That's number one. Number two, of course, treatment as prevention. It lowers the incidence of transmission, therefore improving the scenario of an epidemic that's, for example, here in the Philippines, because there's an increasing number of people getting themselves treated, the infections are still high, but more people know their status and they'll be able to manage their health better and prevent the risk of transmitting the infection to other people. Then next is that it helps us also healthcare providers determine the need for clients to shift medications because every 6 months and every 12 months and every year thereafter we do viral load testing, right? So we see that if the viral load levels does not go down, we might need to do genotyping and then possibly shift the regimen of the client. So it's all part of U equals U. It's not just about being undetectable and not transmitting it. It's also knowing the scenario behind how U equals U actually happens by making sure that you are adherent and making sure that you know what's happening with your treatment regimen. Therefore, you'll be able to understand your health status better and take care of yourself better. So that's the first one. The second one is why is it important to inform PLHIV clients or patients about U equals U in the healthcare setting? Well, we are all humans, and I believe that, based on mass society of needs, self-actualization is part of the highest form of, accepting oneself and dealing with one's holistic being. And when you are undetectable and untransmittable, when U equals U is present, it actually gives hope to people. It gives an increase and improved health-seeking behavior to people. And eventually, it creates an impact on the quality of life and self-worth of oneself. That's why we at Love Yourself, we believe in empowerment. And part of that empowerment is making sure that our clientele knows about
I'm not very sure if it's my signal or Vince's signal.
Um,
Uh,
it's Vince. Uh, it is currently the interruption
Probably it's
from Vin
Vince's signal
from
that
Vin's
is
signal.
lost. So while we are waiting for Vin to get back to us, I mean it's in the middle of this excitement. Yeah,
Yeah. So thank you, Dr.
yeah,
Nitya. It
yeah.
was we are waiting for Vin to join back again. But yes, please
Mm-hmm.
please do proceed. I think he got lost with it from the connection.
Yeah, but I think we got already a very important point shared by Vin and also by Baby as well. So while we are waiting for Vin to come back, join us back, I think we can start some discussion meanwhile, and then we'll give the floor back to Vin when he can reconnect. Baby. Can we get you on with us? Oh, wonderful. So we can see that there are already a few questions for you. So if you don't mind, I would like to ask you the first question. Vin is back. Yeah. Uh, yeah.
Sorry, the Philippines is notorious for bad data.
No problem. We are so glad that you can reconnect back. Why don't you continue with your first round of presentation? Is that okay, Baby and Inat? Yeah.
Yes.
Yes. Okay. Vin, we are hearing you from the part about self acceptance, so you can continue from there.
Yeah, so as I was saying, when our campaigns go around the idea of having hope, improving our seeking behavior, and eventually improving the quality of life and self-worth of our clientele, because our ultimate goal is to promote self-reliance and promoting one's, acceptance of oneself. In our community center, we test around 50,000 people every year, and we currently have around 7,200 clients on our treatment program. I think 80% of them are on treatment already. And based on the recent data that was given to me by our data manager, we saw that around 90% of those clients who are on ART for less than 7 months are virally suppressed, while clients who are on 8 months to 13 months of ART are around 90% viral suppressed. But for those clients who are post 14 months, around 95% of them are viral suppressed. And it creates good health seeking behavior to our clients that before you need to contact them for them to actually get their refills, but now they actually go on their own, they contact our hotlines to make sure that their refills are delivered on time, especially right now that there's a pandemic, that we had to innovate and make sure that the deliveries of the medications are on time. And since mobility and transportation is really hard in the Philippines up until now, because the Philippines, I think, has the longest quarantine. We're on quarantine for the last 10 months. And it's really challenging. But, thanks also to our clients who are empowered. They're actually the ones who are asking for making sure that their medication arrive on time. So it's actually a give and take relationship for the two of us. And also, of course, we're very thankful to our celebrity allies who have been very helpful in the Safer Now PH campaign that we have been doing with Upcom and Skipa Afeo. We also did a campaign with Catriona Gray and Pia Works back on U equals U. And I'm just using an iPad, so I can't share the video right now. But you can visit do.loveyourself.ph/U equals U for you to see that video. So that's all for now. Thank you, Dr. Nitaya.
Thank you so much. We have learned a lot from you, and also from the other sessions that Love Yourself have been presenting in this webinar. So, if I may, can I have both Baby and Vin and maybe Inat as well on the panel together? Thank you so much. Wonderful. We have had a few questions already from the audience, and I also have a few questions that I would like to really ask for your experience. So, Ina, let's help ask the question together. I will start with the first question to Baby. The question is, do you have champions from government in making you equals to part of the national HIV programming? And how is the relationship of the PLHIV community and the government in Indonesia? I think that's a very, very important question. And if we can learn the tips or the lessons from you, I think that would be very useful for other countries.
Yes, thank you. Of course, we have a champions, but the champion commitment is individual. We want the individual commitment from the government. We want the system commitment. Yeah. So how the relationship with the government? Our relationship is very nice, very friendly. They open up the space for us. They listen to us, but they're not really action to us. So what we suggest, sometimes they just listen. They're not. They're still doing what they want to do. But our relationship is good, and we have champion, but we have to encourage the champion to put into officially U equal U as a national program. But also remember, when they won't commit to into the national program, means they have to commit no stock out of ARV anymore. So when you're asking about, can we ensure the providing the viral testing at the health services? Yes, we can, because we also have a national budget. But the problem is, all the HIV program, sorry if I'm speaking frankly, the all HIV program only want to find the new infection as a target number. There is donor driven. They never talk about me. They never talk about us, who already 17 years living with HIV, who need continue the treatment for the rest of my life, who need the viral testing regularly, once a year at least. They just forget it. So I campaign by myself, for myself, to be a role model for the others. No one support me. I don't want the personal commitment. I want the system commitment.
Mm-hmm. Mm-hmm. That's a very powerful message, and I completely agree with you that more frequently we can find personal commitment, individual commitment, and those commitments gone when the person leaves the position, and we really cannot rely on that. You mentioned about the viral load. Kind of what if I can call it like viral load literacy for people living with HIV, so that they know it is their right to get at least annual viral load testing. Can you also talk a bit more about any campaign or any effort, any education or training that the PLHIV community have conducted in terms of to get people living with HIV who may have already started treatment know that viral load is actually what they need to know, and it's not CD4 anymore. Like many people are still coming in asking for CD4 count and not really understanding how important the viral load is.
Sometimes, if I speak frankly again, sometimes I'm so jealous with the new people living with HIV, because suddenly they just got testing, and then they just got the viral testing, and then they got the new regimen, the single dose, the fixed dose. For me, who already old and 17 years, baby, you just wait. Yeah, let them first. Why they must first? Why always they must first? Because donor driven. Donor just want the number, the new infection, the new target of viral testing of the people who know that. Yes, I'm not agree with that. So we have to make this massive campaign. We have to make a movement building, not only in country but globally. We need more people like me and others to promote ourselves, not to transmit it because we committed, we are undetectable. The way how we can undetectable, the way how we can get the treatment without no stock out in the country level, that's what we advocate for.
Yeah. Okay. I do see that this is certainly a gap, a large gap. If big HIV programs in the country is still driven by the donors, and maybe if even if it's not outside donor, but the current HIV program, the national HIV program, may also forget about retaining people who have already been in care, or re-engaging people who may already lost from care.
For example, who have a program HIV with aging like me? No one. I want to learn from the other country who have a program on that. What the activity they develop on this program? Who funded that? No one.
Yeah,
So
we
they
have
just forget
still.
about us.
Yeah. I do see that if even if it's one, it's usually a very limited, a very small institutional based program. Yes. Thank you very much. That's a very important insight. And now, if I can shift to Vin. Ina, do you have any questions for Vin?
Oh, for Vin, I think the question is now related to what Baby just mentioned about system commitment. Because as Vin has mentioned earlier, it's not just about accessing the ART and also accessing the viral load testing, but also making sure that the resources are there, the equipments are there for the viral load testing, and also the updating of the system itself to make sure that the viral load testing is efficient. So now Vin mentioned about the budget, and from Thailand to Indonesia to Myanmar, there are different counter narratives of against U equals U. Like it may promote condomless sex, or it may promote some other sexual behaviors which are not which the society is not in favor of. So I think my question to Vin will be related to that. So in your experience, what are the common counter narratives against U equals U from the HIV program? And how can we, as a community, counter these counter narratives?
Well, there would always be negative publicity on something that you're promoting, right? So how we act upon it is we create counter campaigns. So by the use of creating, combination prevention campaigns, you actually, before people say something negative about U equals U campaign, you create options for people already. So there's PrEP, there's PEP, there's condom, there's U equals U treatment as prevention. We have other campaigns, and we have options for people who are uncomfortable going to a center, to a government facility, to a private facility. So I think that it's not about people questioning the U equals U, but but how and what community-based organizations and advocates need to do and think earlier on how to manage this possible counter reaction. So usually that's how we do things. So we always do community researches and determine the needs and wants of the clientele. And from there, that's where our campaign starts. We create a campaign on that and we create a program on that. So I didn't actually answer your question, but it's a counter answer to what potentially questions might arise from U equals U?
Hmm. But that is also a very important way of thinking. I mean, because Inet's question asking how should we deal with government or healthcare providers who are so concerned about condomless sex, about STIs, and if we try to answer that by just continue explaining to them that U equals U is not it's not only about condomless sex. It's about eliminating stigma, etc., etc. I don't think that just that knowledge or understanding will help change their attitude towards labeling people living with HIV as someone usually sexually irresponsible. So I don't want to talk to you about U equals U because I don't want you to stop using condoms, etc., etc. I think that's kind of too tiring for us, and maybe just ignore and then talk about what we have to offer to our clients. Maybe the way to go. So it's not like counteracting those negative thoughts from the providers or the governments. Any additional thoughts about this? Baby as well.
Yes. We have awkward situation in Indonesia actually in terms of condom promoting. How we can promote less condom for you equal you. Even we promoting condom, I'm going to the jail because of bill of penal code. We cannot promote condom for anyone. So the bill of penal code, we're still holding the bill of penal code in the parliament. We're still advocating to change the article for the promoting the condom in terms of U equal U. We're not promoting no condom or less condom, but we're promoting to reduce, to end the stigma for people living with HIV. Don't be afraid to me because I won't transmit the HIV to you. That's the message. Not talking about without condom or with condom, something like that. We speak about condom. I will go to the jail. So we are advocating for the bill of penal code not to pass at the moment because the same the sexual concern in Indonesia will be go to the prison as well. So we're still advocating on that. We love for all community in Indonesia. Pray for us.
Oh, yeah. We have to be all reminded about challenges which could be unique in different settings. Yes. Yeah. And so I love when you both of you, Baby and Vin, you mentioned about letting people living with HIV themselves know about U equals U. Nah, and that's partly to gain self-worth, self-reliance, be use U equals U as like kind of long-term motivation for someone to be on ART. I also would like to hear what do you think about having people living with HIV, having their clients themselves educating healthcare providers. Do you think that could be the way to go? Asking about my viral load, asking about my sexual health to the healthcare providers instead of waiting for them to talk to us about U equals U. What's your thought about that? Imat, maybe this could be question for you as well.
Okay, I go first. Uh, so to Baby, we just met first time today, and I'm also a person living with HIV, and I'm still on the Verapin. Wait, someone passed by, an angel passed by. I'm still on nevirapine, by the way, and I'm not, still not changing my regimen. But I normally talk to my doctor and ask her questions. Maybe because I'm working in the HIV field, that's why I'm much more inclined to ask questions to my doctor. And to my surprise, she actually is also being supportive of U equals U, and she tells me that we have to um, we have to make the relationship of the medical providers and the people living with HIV a very good talking relationship, so that the conversations about accessing to treatment, about what needs to be done, because um, I didn't know. So I was living with HIV for since 2009, and then until 2015, I didn't know that I have to get anal pap smear. And for people living with HIV who are male, not necessarily bottoms, we need to get regular testing about anal pap smear because of potential anal cancer as kind of like an infection. So these kinds of conversation needs to happen inside the clinics, not only because we want to know whether we have to change the regimen, or whether or not I want to have another set of medicine, but also what are the other factors that are being affected because of me living as a PLHI, living with HIV. And I think I'm going with Vince. I think that not only Vince, but also the community's opinion on promoting sex positive communications, to make sure that like we should be more confident about our sex lives, and we should not get ashamed about that. And when we are empowered, that there's nothing wrong with our lifestyle, then we may be the ones asking questions to our doctors or case managers. Yeah.
I know second. So I think asking questions is a sign of interest. And healthcare providers should take that as an opportunity so that we can empower our clients better. And and these clients they are social media people. So once they know more about the things that your healthcare facility is promoting, then they themselves become advocate of the campaigns that you are promoting as well. So it's just basically creating a domino effect. So if you empower one client by telling them about the campaign that you're doing, such as U equals U, then it creates ripples of positive change in the community. So I think it's a good thing that we share it, and we're evolving when it comes to healthcare. Here in the Philippines, due to the pandemic, we have been doing telemedicine to most of our clients. And there's always Twitter and Instagram, TikTok, people who might not be healthcare professionals but who are advocates. It's very nice that healthcare professionals also download this information to lay people in in terminologies or in ways that they could digest, so that they can share it to other people in a more proper way. Because sometimes some concerns of clients when it comes to healthcare professionals is that they speak too technical. So they tend not to understand that much what the healthcare professional is saying. But if we translate it in a way that's palatable to our clientele, then the messaging and the echoing
Are you still there? Hello? Oh, he dropped off again. Um,
Debbie, you may want to jump in here. What's your thought about initiating interaction between?
Yeah, I'm totally agree. Initiating for the healthcare or health provider to promote this one because in Indonesia we are very low people living with HIV on treatment. We are very bad score in the world. Why? Because no one promoting you equal you, especially from the health provider, especially from the health worker. We as a new HIV positive people listen to our doctor. So if the doctor not promoting you equal you, how can we get adherence on our treatment? And then what regulation you equal you on the system? No, no regulation from the national level. And also no guarantee that ARV not stop out. There is the challenge. But I'm totally agree. If we can influence the health worker, health provider to have better understanding, to promoting together with us, it will be very good. We can increase the people on treatment. We can increase the people adherence and we can achieve you equal you. I believe that.
Yeah, thank you very much for sharing that. And if I can, Inet, I also would like to share some of our own experience in Thailand. We don't have U equals U mentioned anywhere in our national campaign, in the guidelines. No, we don't talk about U equals U. And we know that in the community-based clinic, in the key population-led clinics, for example, we have been using U equals U not only to get people be adhere to their treatment, but also as a way to get people to come in for testing. Because people know that when they come in for testing, and if they test positive, they can start ART immediately to achieve U equals U as soon as possible. And in addition to PrEP, right? So it has been very successful in getting people into testing. And at the same time, we started same-day ART initiation 3 years ago. And I think that's the only sentence that we use for people who are newly diagnosed with HIV, that, okay, now the goal is to get you to U equals U. And 95-98% of people will say that, okay, let's give it a try. And they know that next time, 6 months, they would want to know their viral load because that's the motivation since the first day of ART, right? But I have to say that it's in a very small world of us doing this. When we talk about U equals U outside of these community networks and to like professors in university hospitals, I think that people don't really get to this point and are still like stuck with their probably implicit stigma towards people living with HIV, not wanting them to know about U equals U too much, selectively tell certain clients, but not everyone. Just the client that you trust, that they would continue using condom, that you will talk to them about U equals U. So I think that's probably an important point for us to think about how to integrate U equals U in a more systematic way. We may really need to get U equals U into national guidelines. Have a formal language in the guidelines of trainings for healthcare providers that they cannot avoid just talking to a few clients, but not every clients of them who are on ART. Yeah, so that's my addition to this. Yeah,
If I may, Dr.
I
If I may, Dr.
yeah.
Matea, Vin is dropped off again. I think, I think I agree because the no, not I think I agree. I think the question earlier about the counter narrative is about, okay, if we present the undetectable was untransmittable to the HIV program, what will be the counter narratives from the program itself, but not from the people? So I think I have listed down from the conversation. Number one, if we are trying to ensure updated equipments for viral load testing, and also making sure that these equipments are accessible to each and every PLHIV, then there's the question of budget. Where are we going to where are we going to get the money to buy for this equipment or to update the equipment? The second one is about the effective supply management. Like the supply management of ART is fixed, is institutional. We don't like we need. Those are the counter narratives that kind of like from the program perspective that I'm getting from the conversation. And I think if we are really going to make the U equals U as part of the national program, then us as the advocates of U equals U have to think how do we counter this counter narratives so that it will, because to how do you call that, to be part of the program itself because it contributes to the goal. And I think the question here, like how do we use the third 90 to push U equals U into programming? I think that's related to the program like counter narrative question. If we are going to have like ARV like commitment to no ARV stack out, and also the making sure that people living in HIV are accessing viral load testing, can we use the third 90 to push the U equals U programming? I think that's the question.
Yeah, baby, would you like to add to me?
90 to push this U equal U, and also the third 90 is viral suppression, and as part of the universal health coverage, as part of the SDGs, and all the country commitment on that. So we can use this strategy, we can use from this way. But also we have challenges to do that. But don't think about the challenges. We're facing the challenges the whole life, in our life as people living with HIV. No need to worry about it. But I have a recommendation. We need more dialogue on this, on U equal U. Like you said, Dr. Nitaya, don't have any guideline on U equal U. Not even the health provider can promoting this because they also not sure about this. Yeah. They also still ask a woman living with HIV to go for cesarean, not deliver the baby normal. Still for the not give the breastfeeding. So we need more dialogue. We need more campaign. We need more champion. Not only at country level. We need massive campaign. Like last time, we campaign about what we campaign about, that the very massive campaign when we talk about the GPA principle, how we can grab this opportunity, we can sit together with all the decision maker to voicing out the needs of people living with HIV. Takes time, almost 10 years. Now we can start from now. As long as we have people like us, still alive, still healthy, pretty, sexy, not transmitted, happy, enjoy the life. What else?
Yeah, I'm so happy to hear from you, baby, because I don't know if it's happening like this in any countries that we have like a representative from people living with HIV who have this self-worth to share with others that I'm really happy and not transmitting HIV to anyone. And you are pretty. That's what's important. Yeah.
Yes. Too pretty, too sexy. Untransmitted, undetectable. Ow!
Yeah. Yeah, I feel that this is also important. Like we are relying on doctors to talk about U equals U, but I think equally important or even more important is that we have someone who can like speak out loudly to the community that I'm living with HIV and I'm not transmitting HIV to anyone and I'm very happy. We don't have anyone like that. Like we are talking about government champion. Now, if we have people living with HIV champion in the country, I think that is also equally important. But in let's say in Thai society, I think people are so afraid of talking about U equals U, even especially if you are people living with HIV, because people will instantly blame you of talking about this because you want condomless sex, right? And that has happened earlier this year in our country. And so I think like at least Thailand, we will have to learn a lot more from other countries of how the HIV communities stand out and speak out about U equals U. Yeah.
Yeah, at the moment, I think that it's look like because we just starting this campaign. It's look like we defend ourselves. Yeah, we defend ourselves. I won't transmit it to you. Don't worry. Don't afraid about me. I won't transmit it to you. If I transmitted my HIV to you, I will lose my job. What? I don't know how the alternative is. I don't want that. That's just kidding. So this we need more people to speak about this. Not only knowing the status on HIV, on treatment, adherence, and then what else? How you maintain your life. The life not easy as you talk. There is up and down always. So when you healthy, you happy, everything will be good for you.
Yeah, thank you. Inat, you seems like you want to say something.
Oh, because I noted down, Baby has mentioned about the guidance or the guidelines for medical service providers. So earlier this morning, there was a presentation from ASHM. So Australian Society of HIV Medicine has launched just last week during their ASHM joint HIV and SRHR conference the guidelines for medical providers on how on the U equals U. So there was a presentation about the communications, like how the medical providers will be able to communicate effectively and clearly to the patients or clients about U equals U, and also some of the challenges or barriers that we might face in terms of advocating U equals U with medical practitioners. So I think it's available for download at ashram.org.au, and I'm really promoting it. But for us to use that, it's useful. And maybe to kind of share that there are also stages of acceptance for people living with HIV on the HIV status. So it's like stages of grief. So there's like disappointment, and then there's this
Dada.
denial. There's this
Blaming.
yeah, and like the fear, because when like especially for private companies or PLHIV who are um, working in private companies, and also not out as a gay person, there's this fear and denial of having living with HIV, and I think both Baby and I have already passed that stage already. Like we don't care anymore. But I think
I don't care.
yeah, the overall stigma and the overall perception of the society on HIV adds up to that burden of coming out, and actually, parading that, I'm undetectable and I don't care what you're gonna say. And I think it's I don't know. I think I have to put the microphone now to Vin on, because they're more focused on empowerment and confidence and self-worth, for people living with HIV to actually speak about it.
Hello. Well, just like what you said, Ina, for our clients who are newly diagnosed, most of them, I mean, we have a program called life coaching because we understand that everyone needs to undergo the grieving process. So, as you were mentioning, denial, anger, depression, bargaining, acceptance, every person needs to undergo that in different phases, no? So as soon as the person, and doing these campaigns on U equals U actually kind of, speeds up the concept of grieving because you will be looking forward to something, not just sadness. It's not like before during the 80s and the 90s that if you're a person living with HIV, it's a death sentence for many. But now it's a different scenario that there are living proof that you can live a normal, healthy, happy, beautiful life, just like me and you. And we need to streamline people like you, heroes like you, who are willing to step forward the limelight just for other people with HIV who are not ready yet. I feel that, there are people with HIV who are empowered and plus the campaign of you equals you, it creates a greater impact on the persona of a person because we have
Yun.
deep-seated issues that we need to address. And by doing campaigns that focuses on not just on biomedical aspects, but also the mental and mental health aspect of the client. And U equals U is actually partly medical and partly mental health because it creates it makes you feel better. That's number one. And actually, your body feels better. So there.
And also make you confident to talk about yourself, right? And but on the other way, be as a lead in this campaign, we also have to ensure that the availability of the treatment is there. No more stock out. That's very important. And also the affordable of viral testing. So
Agree.
we have two different roles. The first we have to show ourselves with the happy life, confident, beautiful, sexy, and so happy and enjoy our life. And the other way, we also have to be very serious to the government to ensure the treatment and also viral testing is there, affordable for all of us.
Mm. So,
Here,
so it's
here.
Right?
advocacy plus service delivery.
Yes.
Yeah. And which is programming as a whole. So,
Yes, and I think it's actually a good um, timing for us to rethink about viral load testing. We have been using laboratory-based viral load testing with a long turnaround time in a way that
Yes.
we almost could not use it to talk about U equals U. Why
Yes.
we now have a better technology and actually cheaper viral load testing, or beyond that, we can actually pull 10 samples from patients into one testing because most of you on ART
Yes.
will become undetectable. And if we can just pull the samples, then we pay just 1/10 of the cost. And I think that if we can use kind of this point of care technology, then we can really use viral load testing to talk about U equals U immediately to our clients. And I think it is probably something that, like, as a region, several countries together, we may have to send our voices out to several governments altogether. That's one thing that I think we probably will have to think about viral load technologies if we are going to talk about U equals U in a more systematic way. Yeah. And I also, I mean, we have baby, we have Inat who can like talk very happily with confidence. But at the same time, I also think that at least that you will need to have some healthcare professional back you up in case like someone attack you.
Yes.
I don't know if you have good examples in your country on any doctor champions who may not be government champions, right? Maybe like your personal doctor or something. I know, Vin, you have your hot doctors, hot nurses.
Yes. Yes. Yes.
So
They're
many hot
advocates.
doctors.
They're advocates of U equals U.
Yeah, and I find it really hard. I don't have hot doctors and not even hot doctors talking about you equals you. So I really feel like
We
very
have in
frustrated.
Indonesia. We have in Indonesia. But he's a dentist. But at least he part of this campaign. You equal. We have hot doctor as well.
And I think
We have hot doctor and hot mama like me.
no, that's what I'm gonna say.
Hot doctors together.
That's what I'm gonna say because from the last conversations we discovered that U equals U. Well, it's not really a discovery, but it's given that U equals U is not only for MSM but it's for everyone who's living with HIV. So I think from the hot doctors or hot nurses champions, I was leaning more into the efficient mothers or hot mamas champions who are living with HIV whose children are negative, right? So yeah, that's what I was thinking.
And Vin, I mean, I asked your colleagues during the last session how they identify those hot doctors and hot nurses. I know you have been doing this wonderfully. Any things you can like give. Let's say talk to Dr. Nitaya, give her some tips of how she can identify some hot doctors in her country.
Dr. Nitaya, Dr. Egg. I'm just kidding. Anyway, so just that of course Thai Red Cross has been very, very supportive to Love Yourself, especially in our trans program. Erie has been doing a lot of help, and Kun Gemma last week just provided technical assistance and training. And if there's anything that we can assist you with on the end of Manila, let us know, Dr. Taya.
Thank you. So send some of your hot doctors to Bangkok, na?
When we're able to fly already.
Thank you. Yeah. And in that, I don't know when we have to end this session, but I have one more question, which actually is related to what Baby mentioned about donor-driven targets, because we are talking about programming here. Our experience receiving money from USAID through linkages and now EPIC programs, we know that Thailand is not doing very good for the second 90 as well as the third 90. Because the second 90, we only reach 70% overall of people living with HIV, knowing that's who started ART. So it's such a waste of resources, energy, and time for getting someone to know their status but not starting treatment. And we think that here U equals U is probably the main weapon that we can use. But then the third 90, we mentioned about that a little bit. My experience is that I don't know if it's true for you in the Philippines and Indonesia or not, but we only have 60% overall of people on ART who had their viral load testing over the past year. But among those who tested, and we have high viral suppression. Yeah, so I think this is something that may be related to viral load literacy that we talk a bit at the beginning, because it's very unusual for a client to ask for viral load. It's just that the doctor say that now this is your CD4, this is your viral load, and they don't even know which blood test they will get from the that blood draw that they got. So I would like to hear more from you on what you think about this, how we should propose this in kind of a unified voice to the donor, because I think that would really help push the program forward.
Mm. Well, I think for the Philippines, we are very far behind. But I can only speak for Love Yourself. Love Yourself is supported by any grant when it comes to our treatment program. I think we have 20 clients every month who is supported by a Healthcare Foundation for their viral load testing. But the rest of our 7,000 clients, Love Yourself created this model that is a social enterprise, and we are currently self-sustaining through the Philippine health insurance. Though it's delayed by 9 months, at least we're kind of moving forward. So we're able to provide viral load testing for our clients for free. Unfortunately, due to the pandemic, our usual 95%, wait, let me correct that. Our usual 95% access for viral load went down to around 88% because some of our clients live in far-flung areas, and we have a program wherein we go to their areas and extract blood. But unfortunately, if the client lives in other part, Philippines has 7,100 something islands, and it's hard to reach some of the clients. So that's a challenge right now. And one more challenge is that as much as we have campaigns on viral load testing, and U equals U. The issue is we do not have that much point of care viral load test GeneX machines. We have the big hospitals who do that. Unfortunately, they are overburdened. So hopefully in the next grant, um, our funders will focus on more on procurement of point of care devices so that the turnaround is easier, it's more affordable, and more clients in far-flung areas can be tested with viral load tests because you can just carry it, and then hand carry it in the plane, and then you go to a town, and then set up a space there, and then our clients, you just contact our clients, ensure confidentiality, and then you do the viral testing, and then you get it after 4 hours or so. So, maybe, to make it shorter, you just need to innovate and make sure that we utilize point of care devices. Because if we use, of course, there would be people who prefer the big laboratories. But when you're dealing with people in the community, you need to bring the resources to the community, and there are available, point of care devices. And that's something that I think we should push for because it's more affordable. There's value for money, and you make sure that the client knows the concept of viral testing and U equals U.
Thank you, Vin.
Right.
I hope that the government will think about these things in this simple way, no, and just start doing it as soon as possible. Yeah, thank you, Vin. And maybe you would like to
Yeah.
give your
Well, here we have a lot of innovation to reach the new people to get testing. We are good in that. But in terms of the second 90, we have to chasing the people who are lost on treatment with many, many things of reason. Transportation issues, affordable of medicine, the stock out, etc. And the third 19, no one talk about it. This just a slogan. So we have to lead this from now. We have to become a champion on this from now. Don't count on the health provider. Don't waiting for the guideline. Just come out.
Come out and demand.
Wonderful. Yeah, and thank you so much. I feel I have learned a lot, and I now know next time I meet with my government, what I will say to them. And lastly, because I think we have around 10 minutes more. We talk about guidelines. And I talk about the ACHIM guidelines, which is really wonderful. And I also think that we heard from Taiwan experience yesterday that is probably the first country in Asia that has integrated U equals U into its national guidelines. I think that would be like the most sustainable way of getting U equals U into continuous discussion at the country level. But meanwhile, I think I don't know, Inat. This may be a question to you. Do you think that being AppCom and you are so good at producing this very easy to understand communications tools. Will you be able to do something like that for people living with HIV communities, KP communities, to use to educate among themselves and probably to empower them to start talking about this with the healthcare providers before we have national guidelines in which healthcare providers will listen to the guidelines rather than to community organizations like us, right? What's your thought about that? And maybe Baby and Vin, if you would like to share your thoughts, that would be wonderful as well.
Um, Thank you for that wonderful question. AppCom, like I'm a person living with HIV. That's not really a secret. And when U equals U was announced, I was really excited, and it was Midnight who actually pushed me. I mean, I do not really openly identify myself as a person living with HIV, but it was really Midnight who pushed me to go out and say that you are a person living with HIV because it creates a lot of impact. And I think for me, speaking as a program officer of AppCom, one of the main challenges is the language barrier and the kind of making sure that the community understands what we're trying to say. From the consultations and the conversations that I've had with our country partners, one of the things that they have mentioned is why don't we kind of like summarize all this and make it like understandable for community, or why won't we have like a generic or like a regional key messaging on U equals U that we can use for our dissemination of information, and then the country can just adopt it at the country level. And I think that's the way that we are treading, the path that we are walking on at the moment. And I agree with Dr. Ndintia about the making sure that the language is very simple, and the literacy will make the literacy will be much easier if the community understands the information really well. And I just wanted to kind of comment on the funder donor discussion earlier, because I think when we talk about ending AIDS by 2030, we or the donors, or maybe our subconscious, because we have been doing this for a long time, our subconscious is always prevention. And when the EPIC project was like announced or introduced, EPIC means epidemic control, so EPIC by FHI 360. And when I learned about it, I was thinking, oh, if we're controlling the epidemic, then we must also make sure that the people who are living with HIV are also retained on treatment, so that they become undetectable and therefore untransmittable. So I think that's the argument that we used in APCOM to make sure that UECOSU is part of the program, to attain epidemic control. Like we kind of make sure that the treatment and the adherence will be part of the entire prevention or the entire strategy in fight against HIV. Um, yeah, I think that was the question, no?
Yes, thank you. I'm glad to hear that it's already in the plan that you will have this like easy to digest information, U equals U message that we all can use before we get a formal message into our guidelines. Yeah. And Vin and Baby, any last comment that you would like to make on this? Maybe some message that you want to send to your government, HIV program persons in your country or in Thailand or elsewhere in the world.
Yes. I have experience with the PMTCT guideline in Indonesia. So how we can
You go first.
adapt this guideline to complicated guideline, literacy on PMTCT, and we adapted into a comic book for our community and very success the last 3 years. So I got this idea how to adapt this U equal U literacy into a comic. So easy to understand and very favorite as well for the health provider in Indonesia. So we can do that. There is no language barrier. We just read it and then we hire some professional to make a cartoon and like a comic book and very easy to understand. I'm sure we'll be success. Going to support. We're going to support.
Thank you. Thank you. And Vin, please.
On my end, well, number one is demand generation. It's important for us across Asia Pacific and the whole world to create demand generation on not just U equals U, but combination prevention, treatment as prevention, so that more and more people will, get awareness, not just awareness, but there would be action that's taken after a person knows about the different concepts of prevention. And then number two, if there's demand generation, there should be service delivery. So I'd like to reiterate what I mentioned a while ago. I hope that the governments will look once again on the concept of point of care devices because it's gonna make things easier for community people. Just for example, Love Yourself has 7 community centers across the NCR, and we're supporting 15 community centers all over the Philippines, and it's gonna be helpful not just for community-based organizations, but also for social hygiene clinics and government facilities because it's easier, it's more accessible, and it's not just via load. You also test for TB, TB risk, because we all know most of our clients, I mean, in our case in the Philippines, 15% of our clients who are newly diagnosed also have tuberculosis. And if you have a program that's not just TB program, but also a TB HIV collaboration program, it becomes more holistic. And you can do that by having point of care devices, right? So that's one, demand generation. Number two is service delivery. And number three, Ina, this is your favorite, a program and a policy that would back it up. So there would be budget that would make it sustainable.
And
I'm
cost
a good student,
efficient.
Ina.
My favorite. So number one is demand generation, number two is service delivery, and number three, cost efficient and sustainable program. Okay.
Yeah, and the point of care thing will be able to be used for gonorrhea, chlamydia, hepatitis C, and everything as well. Yeah, that's wonderful. I think we need a
Yes.
louder voice
FAI
now that
awards.
we send voices. Yeah. Okay. I think we are coming to an end here, and this has been a very rich session. I truly admire both Baby and Vin of what you have already done, even without obvious support on this issue. But we, like you said, Baby, we don't care about challenges. Challenges is always there. We just want to get over it, and then be towards another level of challenge, and nothing can stop
Ayan.
us. Yeah.
Nothing can stop us. Ikaw
Yeah,
ang
so
mag-isang.
yeah, and thank you very much, Vin, for you your like a wide scale vision, no, of all the initiatives that you have been doing in the Philippines. I think that the whole region can certainly learn from you. And so and lastly, I would like to thank AppCom and all the hosts of this session to make you equals you being discussed formally for the first time in the region. I truly appreciate AppCom's effort on that. So I would like to send the microphone back to Inat if you would like to say something to close the session.
Oh, okay. Thank you so much, Dr. Nitya, for supporting AppCom, and for also to agree to speak as a moderator for UCOSU. Thank you to Baby and to Vin. I love you all. The Dr. Nitya mentioned. I have nothing to add, but yes, I love you all. So I think I will have now the pleasure to thank the International Aid Society, the International Aid Society Educational Fund, the VIV, and the Gilead for supporting the RAP conference. So the APCOM Community Summit is a 5-day event. The first day was the pre-conference last Monday. Yesterday and today is the RAP conference, and tomorrow and Friday will be the LGBTQI Business Forum, making sure that the LGBTQI community is also being engaged in the private sector. But for the RAP conference, this won't be possible, especially the virtual conferencing, without the support of the IS and the IS Educational Fund. So
Okay, so thank you very much. Thank you, all the audience out there. We appreciate
Thank
everyone's
you.
attendance. Thank you so much.
thank you so much. Have a
Thank
good
you.
night.
Bye.
Thank
Bye,
you.
baby.
Bye.
Keep
Bye.
safe.
Thank you.
Thank you. Thank you.